thank you for that kind introduction and for the invitation to talk with you today. How many of you are planning on watching the Super Bowl tomorrow? Pretty good number. And you probably have your team picked out. I'm not ordinarily a big professional football fan. I like sports a lot. My son is a basketball coach, so basketball may be a bigger deal for me. But I'm told that tomorrow's game features the NFL's best offense playing against the NFL's best defense. And as I was thinking about that a little bit, it seemed like a good metaphor to build my discussion about the future family physician, because for the last 15 years, folks, our specialty has been playing defense. We have been reacting to the world around us. We've been trying to avoid losing ground. We've tried to protect our practices and our patients and our communities. We've tried to protect our specialty during a really chaotic time, both with the economy and with the change process in our country. As I think back on it, for those young people in the group, you may or may not know, family medicine started as a specialty in 1969. And there's really only been two periods in our history where I would say we were playing offense. In the 1970s, we went from 15 residencies to 350 programs in a single decade. And the generation that built our specialty came out of private practice against pretty considerable odds and have now built one of the largest specialties in American medicine, certainly a success story. In the 1990s, during the managed care era, I would say family doctors on offense turned the ball over. We fumbled or threw a pass interception. And so for 15 years, we've been trying to protect our turf. And today I want to talk a little bit about playing offense and a little bit about what that might look like. And to do that, I really need to tell you in some detail what my practice of family medicine is like in Oregon, because we now have enough diversity across the country that each of us are living in a kind of a different world, if you would. And I think if you understand my world, then you can put my comments into better context for your own. So every month, I get a report that looks like this. We have been fully on an electronic record system in Oregon now for 8 years, and we've had very sophisticated data analytics for the last 3. This is a report about my clinical practice, where we have just about 18,000 patients. About 80% of the patients in my practice, and this practice, the South Waterfront Clinic, is one of 4 family medicine centers in my department, but it's the one that I personally practice in. There's about 18,000 patients in this population. Just pretty much on the button, 80% of these patients are empaneled with physicians. About 65% of the total with faculty physicians and 15% of the total with residents. And the other 20 are empaneled with nurse practitioners and PAs. Now, when I say empaneled, the patients in our practice pick their provider. They have biographical information about us. They choose, based on what they want, who they want their identified provider to be. And this data report reflects the 17,500 and some patients. If you look, it's right up here at the top, how many patients are in the practice. As of November of 2013, this is the report that we've got on those people. And the population is defined by those people who have chosen to be empaneled with one of the providers in the practice. You'll notice that we track clinical parameters here. This tells you the percent of the patients in our practice down at the bottom who have had a resulted hemoglobin A1C in the last 9 months. We're over 90% of the patients with diabetes in our practice have current hemoglobin A1Cs on their chart. And above that, you can see that about 75% of the patients have hemoglobin A1Cs that are at target. And you can see a little trend line down underneath of that, that seems to be trending upwards. I'm going to show you a little bit more about that in a second. But we have information about, what these boxes are on the report is decided by us based on what we want to work on in the practice. And this allows us to compare across our 4 clinics what we're doing. The second page of the report has some other things on it regarding clinic operations. Over 90% of the patients in my practice interact with us on a monthly basis using MyChart, which is Epic's web portal. It means that when I'm here in Nashville, I'm communicating with my patients all the time. And at first, we were pretty worried about whether that was going to be a disaster. It felt like it was intrusive. Well, I'll tell you what, folks, it's a lot less intrusive than the phone ringing. The phone volume in our clinics has dropped to the point where it's much easier to answer the phone calls, and you only have to deal with an email or a MyChart message one time, and it's improved clinic efficiency pretty dramatically. We like to track fairly carefully the length of time that people have to spend when they come and see us. Because Epic timestamps when they check in and when they check out, we have a goal that no one should spend more than an hour in our office when they come for a visit. We track that. We track it by team. We track it by provider. And you can see that we're just about 63 minutes in our turnaround time now and still working on that. And we also attract with some considerable intention, mostly because it's a research interest of the department chairmans, the usual provider continuity index for all the patients in this practice. So what this tells you is during the month of November, 60% of the patient visits were with the patient's chosen primary provider. It doesn't make any sense for them to pick me to be their primary physician and then have all their visits be with somebody else. They have to have some fidelity to that choice. And so we measure continuity at the individual provider level and at the team level, and we have standards for that. You know what you have to do to improve that continuity rate? I'm going to tell you a little bit more about that, but the key to it has to do with the appointment secretaries and the receptionists in the clinic, not the physicians. It has to do with how we talk to patients about what having a family doctor is. We also look at production parameters in these reports. This shows you that we care about the percent of the time in which each exam room in our practice is occupied. The second largest cost to operating our practice is the per square foot cost that we pay for rent for the practice. In order to maximize or actually minimize the cost per visit, we have to turn those exam rooms over quickly. And so we measure the percent of time they're full, and we have standards about that. And we also measure the cost per visit in the clinic, because we think in order to make healthcare more affordable, we have to figure out how to do it more efficiently. And this doesn't mean packing more visits onto my schedule, but it does mean having patients waiting for doctors and doctors waiting for patients at the same time is a really bad idea. So we're tracking all these things at the level of the clinic. This is the same report for the Atlantic team. There are 4 teams in this clinic. I happen to be on the Atlantic team. And we have the same report for every provider in the clinic. This is mine. It comes out every month, and it hangs on the wall of all the team rooms. Every intern in my program sees the quality standards from my practice and from everybody else that works there. The medical assistants in the practice see this. Getting those hemoglobin A1Cs ordered is a medical assistant job in our practice. It's not a physician job. And for them to know how they're doing, we have to show them, because they work with individual providers and within teams, if that makes any sense. So then if you have this kind of data for a while, okay, and you all at once are able to start looking at how things change. So this, as our Gabriel Park Clinic on the top and our South Waterfront Clinic on the bottom, you may not be able to see the headings, but it's the percent of people who have hypertension, who have blood pressures that are under control in the green and are out of our control parameters in the red. Now, this is not an easy thing to do in practices that have 18 to 20,000 people in them. And we're really proud that we're accomplishing this. All the teams in the clinics know all about this. And I'm showing you the 2 clinics together because I can tell you they're competing with each other. And the teams within each clinic are competing with each other. And we're starting to move the number. Now, I don't know whether 80% of our, and I think some of those numbers might be hard to read, that I don't know whether 80% of our blood pressure patients being under control is good. I don't think you know whether 80% of our blood pressure patients having blood pressure controlled is good, because I'll bet you that hardly any of you know what that is in your practice. I didn't get into medical school by getting 80% on tests. But if a baseball player gets a hit 80% of the time, they're in the Hall of Fame. I do not know whether 80% is good or bad, and we don't worry about that. We just worry about whether it's getting better or worse. And we worry about who the 20% are and why they're not in control and what other things we need to be doing to be able to reach them adequately. I told you a little bit, we're very serious about the usual provider continuity index in our practice. This is from a paper we did that was published just in the past year, looking on the top at the relationship between how often people are in clinic and what their continuity rate is for their patients. This is, each dot on that curve is one of the 63 physicians and nurse practitioners and PAs in our 4 practices. It's a beautiful regression line, isn't it? I can tell you the way our clinic culture is currently working, exactly how big of a practice you need to have if you want to have a 70% continuity rate. We're learning now how the slope of those lines can be changed. So at the bottom is how big is the practice per FTE of the physician, and at the top is how often is the physician in clinic per month, right? So we can decide if we want to tell our patients they can see us 3/4 of the time instead of 2/3 of the time, exactly how panel size would have to be adjusted in order to deal with that. This is a science of family medicine that has never been in our grasp before. And we're playing with this every day where I work, which makes me pretty excited about going to work. Now, we also operate 4 family medicine inpatient services and do over 2,500 hospital admissions a month onto our 4 hospital services. We've become very interested. This looks at one of those hospital services, which is the service that all of the admissions from the South Waterfront Clinic go to. The South Waterfront Clinic inpatient service, we all take our turn attending on that. There's a few faculty that don't do inpatient care, but currently about 80% of us are doing inpatient care as part of our daily work. And we have, like many places, been focusing on the readmission rate, the 30-day readmission rate to the hospital, as something that our hospital cares a great deal about. And you can notice as we've been working on that 30-day readmission rate, we've got it down to about 12 or 14%. I'm told by people who study such things that that's reasonably good, or it's not shocking. It's not worse than everybody else. And you can see that since we started working on it about a year ago, it's been getting better. Our focus has been on a whole bunch of things, and I'm not going to go into the details of what we're doing exactly there. But I want to show you something else that's actually really important emerging data. So the graph for the patients that are actually getting continuity clinic in our own practice is the second one or middle one on the slide there. And the graph, we also admit onto this service patients from 10 community health centers that are in Portland. The 10 community health centers are populated by physicians and nurse practitioners, many of whom are graduates of our residency, who don't do inpatient care at all. We communicate with them pretty well, I think. We're functioning as their hospitalists. But even though the inpatient team is exactly the same, I want you to notice that there's a 33% hospital readmission rate on the bottom curve and a 5% hospital admission rate in the middle curve. What we're learning is that hospital readmissions are most commonly a failure of the outpatient system. They're a failure to take care of patients in nursing homes and rehabilitation centers, a failure to talk with them or visit them or have them in the clinic soon after the hospital discharge. And I think this is a pretty common problem around the country. But this difference is fairly important when we talk about what the scope of a family doctor's care ought to be. I don't think we can be unconcerned about the hospital readmission rate, whether or not we're doing our own hospital care or using hospitalists. So how did we develop a system like this? How did we get to this point? What in the world did we do? Well, first, it took us 2 years to choose and really implement an electronic health record, and some of you are probably still in that 2-year period where your record system is new. I think most of you are probably beyond this stage, but some of you maybe not, and so because we're all at different evolutionary places. We decided early on to build a data team, and people say, John, how big is the data team that gets you all these reports every month? It's currently about 7 FTEs, 7 full-time people. And I get asked, well, who pays for that? I pay for that. Our practices pay for that. We actually sacrificed income in order to buy these data analytics. Because if you want to be able to bargain with health plans and get what you want from your hospital, mastery of information is the coin of the realm. And we were just lucky enough. We also got grants early on, research grants, to do this. One from the National Library of Medicine in particular was very helpful. But the team is now selling analytics reports to 3 or 4 other university departments, and we're in the process of selling reports to community health centers that are in a shared information system with us. Now, when you start getting reports from your data, the first thing you find out is that your data are awful. There's a lot of dead people in your database. There's a lot of dead doctors in your database. There's a lot of problem lists that are wildly wrong. You've got a bunch of people with diabetes that don't have diabetes on their problem list, and you have people who have diabetes on their problem list that don't have diabetes. So there's a big, long process. It was more than a year, really. It was probably more like 2 years for us to really get clean data in this system. Then we had to standardize the way we were going to do the reports. Why did we pick 9 months for when a hemoglobin A1C needed to be resulted? All of those were physician decisions in our practice. Nobody gave us these reports. We decided what our standard of care was going to be based on published standards and based on our own professional judgment. And I would say what we're learning right now is changing practice based on data is a really big, hard task. It involves getting large numbers of people to work on shared tasks, and it requires new skills of family physicians that are way beyond what I was taught to do in residency. So I think, based on my experience, that a new model of population health is emerging in our country. I do not think primary care is any longer the correct term to use for this. I believe the term primary care is really a 20th century term. Because what we're doing now is we're including elements of population health management that goes well beyond what most traditional primary care has done. And this is clearly interdisciplinary with much public health, mental health, and specialty care competencies included at the point of care. The boundary between primary care and specialty care is very blurred. We have 5 different kinds of specialists that come into our practice to see patients there based on the demand for them. And we manage who comes and what they do and which patients they see, but it expands the scope of our work considerably. This new model adheres to well-established principles of primary care, though. It still needs to be accessible and continuous and comprehensive and coordinated and contextual or patient-centered. The new model is based on personal and team responsibility. It's not that I work shifts. I'm still the patient's family doctor, and then that has meaning for how my team works. The new model is rooted in the patient's experience and not in the medical office. And it includes institutional care, whether that's convenient for us or not. It must include institutional care if it's going to be patient-centered. So I think the model looks like this. We've got a lot of family doctors in the country that are mostly working on these things, trying to perfect them. And the use of data can help you to perfect them, to be sure. But when you add on top of that people spend most of their time at home and at work, not in the office, we have to be available to them after hours when they need us, and we definitely have to care for them at the extremes of life, then that is an added set of domains. And up at the top is hospital care, emergency care, and nursing home care. These include ambulatory and institutional environments. Now, you should understand that in this model of care, I am the family doctor for the patient no matter where they are, no matter when it is, no matter what's wrong with them. They need to know that I'm there for them all the time. Now, we've got a lot of medical students in the audience, and you're saying, will medical students go into a field that has that broad of an accountability? Well, I don't work all the time. I'm in Nashville right now. If one of my patients is sick, my beeper isn't turned on. I'm talking to you. So how do I know that I can be proud of the kind of family doctor I am for patients at any of those levels all of the time? It has to do with the group of people that I work with. And guys, I will tell you, to call them a team kind of demeans them. I would tell you that my partners are my professional family. Family medicine isn't just family medicine because we take care of families. We're family medicine because we practice like families. I trust my partners. I would trust them with my children, my grandchildren, my own care. I know that when I'm not there, they're taking care of patients in a way that would make me proud. I need to know that about everybody that's looking after my patients, whether they're in the trauma intensive care unit or on the transplant service or in a nursing home or on hospice care. That's the model of accountability we need to be teaching. Now, I know that this is the right model for my practice. I will never practice any other way, no matter what. I can tell you if the faculty of my department were on the stage with me, they would tell you they know that this is the right model for our practice. I strongly believe this is the right model for my state. As STFM president traveling around this year, I'm not completely sure that I believe that it's the right model for every place, because I'm hearing a lot of people demur at this level of responsibility. I'm hearing timidity, and I'm hearing a certain degree of intimidation. But imagine this, guys. Imagine tomorrow night's Super Bowl game. The first half, Seattle kicks off to Denver and plays a brilliant defensive first half, maybe scoring a touchdown on defense. Maybe Denver scores a touchdown on offense, and the score is tied. In the second half, Denver kicks off to Seattle, and Seattle sends out their defense. It looks across the ball, waiting to see what Peyton Manning is going to do. It looks stupid to play defense when you have the ball. Family medicine has the ball now. And it's time we stop looking stupid and call a play. Thank you for listening.